Okay, good morning or good evening, or shall I say buonasera. Hope I said that right, Dr. Conti. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thanks for joining us today for our first webinar of the Winter SRS webinar series. The series does include 11 talks scheduled between now and May 6th. If you haven't already, I do encourage everyone to visit srswebinars.com, the URL in the upper right corner, to review not only the upcoming presentations, but you can also register to view recordings of prior webinars as well. And one item of business before we get started, if you'd like to submit any typewritten questions at any time during today's presentation, you can do so by using the Q&A button found in the Zoom console. And time permitting, your questions will be addressed at the end of today's talk. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the CyberKnife system, and professor emeritus of neurosurgery and radiation oncology at Stanford University. Dr. Adler.
Thank you, Mark, and welcome everybody to the inaugural talk of our winter webinar series. I'm delighted to have Alfredo Conti lead off our webinar series. Alfredo is a long friend of mine, having worked on multiple CyberKnife related projects in my past life, but he is a noted academic, a neurosurgeon, also a PhD and a great mind who has been an innovative spirit and a widely published radiosurgeon over the last decade. Alfredo currently is in the Department of Neurosurgery at University of Bologna, and I'm delighted that he's going to give our kickoff lecture on frameless radiosurgery for trigeminal neuralgia. So welcome, Alfredo.
Thank you very much. So before starting, buongiorno or buonasera, whenever you are in the world. And this is Alfredo Conti from the University of Bologna. Let me please first express my deepest gratitude to Professor Adler and to the Zap Surgical for this kind privilege of delivering this presentation in this Zap webinar series. And I'd like also to congratulate with John for his continuous efforts to push forward our field of radiosurgery beyond the limits of conventional practice, introducing the most relevant innovations in the field since more than 25 years now. Not only inventing frameless radiosurgery or the ZAP, but redefining the fields of neurosurgery and that of radiation oncology. So we are going to talk about frameless radiosurgery for trigeminal neuralgia, dispelling the controversy, hopefully. So briefly, trigeminal neuralgia is the most common craniofacial pain syndrome with an incidence of up of 5 cases in 100,000 inhabitants. As you know very well, it's a very severe condition requiring long-term medical treatment. Medical treatment is commonly the first option for treatment of trigeminal neuralgia, but often fails. Let's consider that trigeminal neuralgia is a progressive disease requiring higher and higher doses of medications. And this will result almost invariably in the development of severe side effects, including dizziness, gait imbalance, memory problems, metabolic complications affecting the liver, the kidney, and bone marrow. And in the end, almost all patients with high doses of medication will develop some kind of pseudo dementia, which is in most instances, however, reversible by medication withdrawal. So the goal of a surgical treatment, which is offered to those patients, is the reduction of the amount of medication needed to control pain. The first line treatment, surgical treatment, is considered the microvascular decompression. If you try to publish a paper on radiosurgery for treatment of trigeminal neuralgia, you need to assess very, very clearly that the first line treatment is microvascular decompression. I'm not completely sure that this is really true, but let's say microvascular decompression is aimed to resolve the cause of the trigeminal neuralgia by direct intracranial removal of the neurovascular conflict, which is a very good option. But at the same time, it's not a very much complicated surgical procedure, but it requires a learning curve, a good experience in posterior fossa surgery, and for sure it's an invasive procedure. The other techniques are aimed to interrupt the trigeminal nociceptive pathways, either by percutaneous lesioning of the gasser ganglion by using by using several physical methods, or by direct irradiation of the cisternal portion of the trigeminal nerve by radiosurgical technique. And let's consider that these lesional techniques are the first-line treatment for any trigeminal neuralgia, which is secondary to multiple sclerosis, or when no neurovascular conflict is disclosed on neuroimaging. Let's say that we have a remarkable body of experience available in the literature with the use of gamma knife single isocenter treatment of trigeminal neuralgia. But whether the radiosurgical rhizotomy for trigeminal neuralgia can be performed using a frameless technique is still a matter of debate. In this presentation, I will discuss firstly the general concepts of frameless treatment of trigeminal neuralgia, in particular, what is different with a frameless technique. I'll summarize results of a systematic review on the topic, trying to dispel controversies, and finally, I'll present the results from a multicentric study on factors affecting the outcome. Radiosurgery treatment of trigeminal neuralgia was introduced directly by Lars Leksell, the inventor of radiosurgery, in 1952 exactly. And let's consider that gamma knife was invented to treat functional disorders of the brain. It was actually one of the first applications of this technique. Currently, there are some established parameters for radiosurgery treatment of trigeminal neuralgia. As for gamma knife, the treatment is isocentric, using a collimator of 4 millimeters in size, which is the smallest available with that system. And it can be also the size of the isocenter can be also reduced by plugging. The maximal dose has been been debated for a long time, and ranges 70 to 90 grays. In most instances, 80 to 90 grays is the used dose. The target has been changed over time. It has been initially represented by the root entry zone according to the basic prescription of functional neurosurgery and the functional treatment of pain. More recently, Jean-Régis has introduced the retrogastran portion of the nerve as a target, which is also known as the pars triangularis, with the advantage of a reduced dose delivered to the brainstem, which is a very important point. Attempts to treat with two isocenter to treat an elongated tract of the nerve has been also performed, but these has created an hotspot in the middle, which resulted in no pain improvement, but in a higher rates of sensory disturbances, and has been abandoned. Results of radiosurgery for trigeminal neuralgia are widely available in the literature and are rather consistent, I would say. Indeed, high rates of early pain relief can be achieved within few days to weeks after treatment, and generally the response rate are higher than 70% and up to 90%. However, the recurrence affects about 50% of responding patients. In studies reporting long-term results like those you can see here on the slide, it has been found that 7 to 10 years after treatment, about 45% of patients still retain control of pain. And the incidence of sensory disturbances to the face was reported to be around 20%. So what is different with image-guided radiosurgery, frameless radiosurgery? Frameless radiosurgery reduces as much as possible the impact of a surgical approach to the trigeminal neuralgia, we have to say that the treatment lasts 30 to 40 minutes. And with a frameless technique, we don't need to put the frame in the same morning, achieving to have the MRI in the same day and to plan the same day. So the treatment is extremely easy to perform and extremely tolerated by the patient. CyberKnife uses a non-isocentric approach in most instances. Of course, with the CyberKnife, it's possible to use an isocentric technique, but the literature on this topic is quite clear, and non-isocentric technique is the best. But this introduces a serious and relatively unexplored opportunities for treatment. With a non-isocentric technique, the dose, whose range has long been debated, is not the only parameter to consider. Actually, volume of the treated nerve and the dose received by surrounding structures must be taken into consideration to achieve the best results for patients. Given the fact that the doses are extremely high and aimed to ablation of a normal tissue, the question of precision of a frameless technique remains fundamental. The target I personally suggest remains the pars triangularis. In particular, I suggest that the best localization of the target can be identified directly on the CT scan. Of course, we work on the MRI and on the fusion between CT and the MRI, but the CT scan provides a very precise reference point, which is the ostium of the medial cave, which can be almost invariably detectable on the posterior ridge of the petrous bone. And if you look to the tree projection of the CT scan, you can see the bony prominence of the petrous bone, on which lies the nerve before entering the Megel's cave, which is a very, very good reference point. You can see the crosshair is exactly pointed over the ideal target. Here you can see a typical treatment with dose distributions. As you can see, we treat a slightly elongated segment of the nerve behind the gastric ganglion at the entrance into the ostium of the Megel's cave. And if you look to the dose distribution, so the size of the nerve, I will discuss later at this point more in detail, but you can see it's slightly elongated and it is around 5 millimeters. If you look to the dose distribution, you can see how the isodose lines between 10 and 15 are lies outside the brainstem. They are really tangential to the brainstem. There are other points that must be considered, however, and you can see here on this side, you can see that there is something that we have always to take care of, which is the dose to the mesial temporal lobe. Generally speaking, the volume of the temporal lobe receives high doses of radiation is generally limited. It's a very small amount of brain tissue, but the dose to the temporal lobe can be very high if we use this target. So be careful about the dose to the temporal lobe. Of course, all the other structures of the cerebellopontine angle must be contoured, and those volume histograms must be checked. You can see here especially the inner ear structures, and you can see the cochlea, which lies very close to the target. The ideal target should be, as I said before, should be 5 to 6 millimeters long, and that's been defined by Leo Romanelli. I don't know if Leo is listening to this presentation. And Leo worked with John at the beginning of this experience and published the first series from Stanford. And we will see that this is a very important point, the size of the segment that should be considered the target. Because a precise definition of the target, of the size of the target, the volume of the target, will have a great influence on the outcome. And it is possible, according to Leo, to exclude the motor branch, which lies medially. You can see here in purple. It is possible. I have to say that in the literature, chewing complications from radiosurgery with the CyberKnife are quite rare, but they have been described. So this is an option. I have to say that I don't do it, but this is an option. And also there are vessels lying close to the target that it's better to protect from direct irradiations with very high doses of radiation that we use with this treatment. Here, the picture shows how sometimes it is possible to see an hyperintense mark over the nerve after treatment, several months after treatment. This is a very important mark because sometimes this is, I have to say, is associated often to the development of some level of hypoesthesia. But I'm using here this mark just to tell you, just to show you how precise is frameless radiosurgery. The superimposition between the treatment isodose and the hyperintense signal demonstrates clearly the very high reliability of the treatment with sub-millimetric error. This is a collection of, this is the systematic review, is a collection of all articles published to date on CyberKnife treatment for trigeminal neuralgia. The publication started in 2003, and I collected all the series reporting clinical data up to October, the last October. There are 19 case series currently reporting data of almost 1,400 patients. The median dose was 75, the median maximal dose was 75 gray, the median prescription dose was 60 gray, and the isodose line, the median isodose line was 80%. The response rate is very good with the CyberKnife. Of course, there are different rates in different series, but in the systematic review, collecting all the patients' data, we found out that 87.4% of patients who underwent this treatment responded to the treatment itself, which is the initial response, of course. But we know very well that after radiosurgery for treatment, either by gamma knife or by CyberKnife, a certain rates of patients will recur. According to the systematic review of the literature, we found that the recurrence rate was 27.5, which is probably a little bit underestimated because we can see here that the follow-up of most series is quite short, but I will discuss this later also. But let's consider that this result is very good. Concerning toxicity, we found that in the literature, toxicity was reported in about 25% of cases, but severe complications are anyway rare. Indeed, facial numbness can be identified in 17%, but bothersome facial numbness in 7.5%. Other complications are quite rare. You can see anesthesia dolorosa is very rare, which is one of the most of the worst complication that we can see after treatment of trigeminal neuralgia. And so this is a comparison between CyberKnife and gamma knife. I believe that is a little bit artificial, but can provide us with a clear overview of the comparison between the two treatments. I used my systematic review on the one side for the CyberKnife literature, and on the other side, I used the series on gamma knife reported by another great guy who is Konstantin Tuleaska, reporting the data of almost 6,000 cases, 6,000 patients treated by gamma knife. As you can see here, the occurrence of hyperesthesia is slightly higher in the CyberKnife series, is barely statistically significant. We have an very much higher occurrence of bothersome hypoesthesia in the CyberKnife series. So this point must be explained very clearly because in the most recent series and after establishing fixed parameters for treatment, after, especially in the last series in which we decide the dose, we decided the segment of the nerve that must be used as as a target. The occurrence of bothersome hypoesthesia after the first treatment is extremely low, and it is less than 1%. Let's also consider that there is a semantic problem in the comparison between CyberKnife and GammaKnife, and if we consider the occurrence of all sensory disturbances between the two systems, the difference is substantially not significant. You can see 24.5 versus 24.7, so very similar. So in this part of my presentation, I will present this personal work we recently published on Radiation Oncology, which is a multicentric study collecting the data from 2 Italians and 1 German CyberKnife centers. Is a retrospective analysis of data collected between 2009 and 2018. We collected data over 262 patients with trigeminal neuralgia and almost 300 treatments. The minimum follow-up was 2 years. These are the methods: typical trigeminal neuralgia, severe drug-resistant pain, which means grade 4 to 5 on the Barrow Neurological Institute pain scale, single session radiosurgery, non-isocentric technique, using a 5 mm collimator, and the trigeminal node set, which is another relevant point to me because the trigeminal node set, which is a specific path of the robot around the patient head, uses a reduced source to axis distance, SAD, which reduced the real size of the collimators from 5 to 4 millimeters. In this retrospective series, the segment of the nerve that was contoured as a treatment target ranged 4 to 6 millimeters. So I would say that 5 millimeters is okay. Of course, we aim to have 6 millimeters, which is according to the experience of Leo Romanelli, whose data were included in this study. It's better, but it's not always possible because we can have a very short nerve or other reasons for which we cannot reach that length of the nerve. So I would say that 5 to 6 millimeters is okay. The dose ranged 56 to 60 gray, prescribed to the 80% isodose, which means a maximum dose ranging 70 to 75 gray. The minimum follow-up in this series was 38 months. And if you look to the Kaplan-Meier for pain control curves, they show clearly that the pain control at 5 years, as you can see here, was 70%, which is very nice because this result comes from 3 different centers and with 3 different mentality and 3 different approaches for registration of data, measurement, and so on. So I believe that these data are really credible. And if you look to the results, this 70% remains stable up to 10 years. We can see that 54% of patients had no pain and no numbness, and 17% no pain and any degree of numbness. If we add to this patient after the first treatment, so we are the results I showed in the last slides were from after 1 single treatment. If we add patients who underwent retreatments, we can see that the control rate at long term can reach 80% of control, which is very, very good point. Of course, this means that after retreatment, we have a higher rate of sensory disturbances, of numbness of the face, because we will see that retreatment is often associated to the development of hypoesthesia, but also hypoesthesia can be tolerable. So we need to understand how many of those patients have a bothersome hypoesthesia. We try to assess factors affecting outcome for pain, and you can see here that we found two factors that in the multivariate analysis turned out to be independent predictors of pain control. And one is the target volume. So with this study, we added this information to the literature, which is because the volume of the nerve included into the treatment isodose, into the prescription isodose, was overlooked, under-evaluated in the literature. And I believe that 30 cubic millimeters, of course, this threshold was chosen on the base of the median the median volume we found in our series, and then we dichotomized the series to make this multivariate analysis. But 30 millimeter is a very good point. And we added also another information, which is the integral dose, which is a combination of dose and volume. And also in this case, we found that a very low integral dose, below 1.4 millijoule, versus a higher integral dose, higher than 1.4, was associated to pain control. And I can show you here the Kaplan-Meier curve. As you can see, the pain control in patients with a volume inside the prescription isodose greater than 30 cubic millimeter had a very, very good pain control. Whereas patients with a smaller portion of the nerve treated had a worse outcome, and this was statistically significant. And also the integral dose. Higher integral dose was associated, let me say, the integral dose between, you can see the red line means 1.4 to 2.7 integral dose. It's very simple to calculate integral dose because it's the product between the mean dose and the volume. And you can see that patients receiving an integral dose lower than 1.4 had a worse pain outcome. Concerning numbness, let's consider that we have most of these variables were quite fixed. So we don't have great variability, for example, for target length or for target volume or prescription dose and so on. So these parameters were kept quite fixed. So I believe that this is the reason why we couldn't find any association between the development of numbness and these parameters. We only found a clear association between the retreatment and development of numbness. This is a very bad situation. It's not from my series, I have to say, but this can what can happen, because in our series and in all the series series we collected to perform this multicentric study, the dose to the brainstem was kept fixed, and no doses higher than 15 grays was allowed. So there is a very high degree of protection of brainstem. I believe that this is a very good point, because any leakage to the brainstem must be avoided, because high doses to the pons with an imaging like that after treatment is invariably associated to very, very bad very bad complications, not only numbness of the face, but also corneal complications. But as I shown in the first slide, it is possible to avoid irradiation of the brainstem in most instances, and so there's no reason to allow a dose higher than 15 gray, a puntiform dose higher than 15 grays to the brainstem, because the treatment can be performed with those constraints, with this dose constraint. So quickly going to the conclusion, I want to show you just a few innovative papers that has been published recently. This is a tribute to my good friend Leo Romanelli, who recently published this paper, which is a dosimetric study on comparison of dose distribution between the ZAP and the CyberKnife, showing that the two systems can perform very well with slight differences. This is a tribute to John Adler, to Brett Schneider, and other colleagues, and will be the topic of the next presentation made by John. Also for trigeminal neuralgia, probably we are seeing some kind of neuromodulation. As I showed that picture in which we had the hyperintensity signal of the trigeminal nerve, but in most instances we don't see that kind of result after treatment on the MRI. So we don't have a direct radionecrotic effect on fibers of the nerve, or at least this is very limited. And so neuromodulation can be considered one mechanism of radiosurgery for trigeminal neuralgia. And this is my last tribute to Konstantin, who recently introduced this new radiometric measurement, which is he called it BD, biological equivalent dose. Actually, this is a little bit confounding but it's a new measure, which is really interesting because it takes into account the time of treatment, which is very important, and its importance is more and more recognized. Let's consider that with flash therapy, time is extremely important. And what he found is that the time in which the dose is the treatment time, that we call beam on time with the CyberKnife, is associated, for example, directly associated to the risk of development of sensory disturbances. So, going to the conclusion, recent results suggest that targeting 5 to 6 millimeters segment and a volume of greater than 30 cubic millimeters of the nerve, prescribed to a dose of 60 gray with 75 max dose, provides optimal results in terms of pain control. Pain control can be achieved in 70% of the patient, I mean long term, and this can be maintained up to 5 to 10 years. Numbness in our series was only 18%, with only 1% of cases of bothersome anesthesia, which is very good as compared to other techniques. Dose volume calculation, and we measure this using the integral dose, is important to estimate potential outcome. According to our results, the integral dose greater than 1.4 millijoules provides best results. The dose at the brainstem plays also a major role in the risk of development of sensory disturbances. In this series, it was not considered, however, because it was kept lower than 15 gray. So thank you very much from Bologna, the Red City, where I work. I was not born here, but it's a great pleasure for me, privilege to live here, where the university was founded almost 1,000 years ago and became the prototype of a university as we know. Thank you very much.
Thank you, Alfredo. Great evidence that even the oldest university in the world can still do great work, thanks to you. So that was a great summary of I think, radiosurgery for trigeminal neuralgia in general, but specifically focusing on what the CyberKnife technique is. I'd like to point out that there are other examples of frameless rhizotomy for trigeminal neuralgia. I mean, Tony DeSalis has described, has written several papers on the use of Novalis, and I think I'm sure there's other work as well in the field. And I'd like to point out too that you've described how the frameless technique is relevant, but as is the non-isocentric. So in the technique that you've described embodies both framelessness and non-isocentric treatment, which I think is hopefully the combination is the magic technique to get the sort of results you've just demonstrated. And I'd also like to caution the audience before I get to some questions that radiosurgical treatment of trigeminal neuralgia is among the most technically demanding of all procedures with radiosurgery. There is a definite learning curve, and I say this because Some of the worst complications I personally have had as a treating neurosurgeon were in trigeminal neuralgia cases. Now, with the proviso that this was the early days, 15, 20 years ago, and in hindsight, there were clearly things we did that violated the rules that you showed so nicely today, Alfredo. But one has to be incredibly careful because you can injure a brainstem like Alfredo demonstrated here today, and I have done this on a couple of occasions, not paying adequate attention to the lower dose regions. And when you're using 75 gray in a single fraction, the low dose regions mean a lot. And I've heard David Roberge from Miami, from Montreal, refers to them as the fingers of death. You have to pay close attention, even the low dose regions. So I'm going to, there are several people who have asked questions. We've got a great audience, and I'm going to kick off some of the questions one at a time, Alfredo. So first question is, what is the management for patients who relapse after radiosurgery for trigeminal neuralgia, whether it be frameless or frame-based?
This is a very good point. So it depends on what is your approach. I have to say, for example, when I don't like to retreat with radiations. I have to say that my first option would be to make a percutaneous technique. So let's say that this can be expected in 30% of the cases that you treat, as I shown, and so probably the best, my second my second level treatment would be percutaneous technique. This because I believe that we can reduce the risk of side effect from radiation outside the nerve. And so if it is possible, I would prefer not to retreat by radiations, but by a percutaneous technique like a balloon compression, which is quite easy and very effective as well, a little bit more invasive. Of course, there is a lot of literature on the topic. There's no reason to switch from, if you like to perform multiple treatments, there's no clear reasons for switching from frameless to frame-based. It is quite evident that you can reduce the dose about 20%, move a little bit forward if you treated backward your target, not exceeding 140 grays as a cumulative dose between the first and the second treatment. This is possible. Of course, hypoesthesia must be expected. It's not 100%, but I would say that 50 to 70% of the patient will have some degree of hypoesthesia after the second treatment. But the risk of severe hypoesthesia is still low after the second treatment. I wouldn't go to the third one anyway. This is my personal view.
Well, I've even done 3, but but you're right. When you retreat, you have to expect hyposthesia, and if not, total facial numbness. But as you know, we sometimes with radiofrequency rhizotomy, that's the endpoint anyway to get numbness. So it's
yeah, of course,
less than perfect, but I think it is a credible solution for patients who have very, very severe pain. There's someone asked, how does any of this factor in when thinking about the treatment of trigeminal schwannoma? Is it relevant to trigeminal schwannoma in your mind?
The development after radiations, well, I'm not afraid about the development of trigeminal schwannoma or malignant.
No, how does it treat? How is this relevant to the treatment of trigeminal?
I treated several trigeminal schwannomas, and the results can be good in terms of tumor control, a little bit less, especially at the beginning, in the short term or mid-term in terms of pain.
Do you have, I've not seen a big problem with facial numbness after treating trigeminal schwannoma. How about you?
Yeah, of course you will have, but the patient is going to have a facial numbness anyway. In that case, we are not treating functional disorders, we are treating something more complicated. And if you send the patient to surgery, he will have hypoesthesia for sure. So I believe that the problem is less relevant. The problem is relevant with functional disorders like trigeminal neuralgia, in which you want to relieve pain without having toxicity, but this is not always possible, and you should try to stay in the middle to have good results in terms of pain control versus a small area of hypoesthesia around the mouth or something like that. With schwannoma, I believe that problem is much less relevant because the other solutions are anyway more complicated, and I would expect some kind of hypoesthesia. Let me say that the dose to treat schwannoma is much lower, of course, but the volume can be much greater. The problem is not the dose.
So you pointed out on your talk about how the CT, axial CT, can provide a credible landmark for identifying your target volume. So someone asked a question is, can you go back to that methodology and how do you identify the target volume? And I guess my question is, you would never target just off identifying the trigeminal ostium. You would always use combined with additional imaging information, correct?
Yes, I believe that if you look to the three projection of the CT scan, of course, the target should be identified on the MRI. This is clear. But considering that the image fusion introduces to a certain level some sort of uncertainty in a new level, a different level of possible mistake in planning. So if you have something on the CT scan, which is very spatially reliable, because the point is that each peak, you can go very in deep with the CT scan and making increasing the size, zooming on the CT scan and look to a single picture and to a single pixel, sorry. And you can see exactly where the entrance to the megalscape is. And if you move from the CT scan to the MRI, you will see that this point, which is the bony prominence, is a bony prominence you can see on the three projections. And that portion of the nerve lies over there, invariably lies over there, because it's the entrance to the megalscape. If you see clearly the megalscape, you see the bony prominence, which is the ostium of the megalscape. In that point, you will find the nerve almost invariably. And this provides you very confidence that you are treating the right portion of the nerve.
Can you comment on immobilization when treating framelessly?
Yeah, of course. This is a very, very, very controversial point. Some kind of, when we treat trigeminal neuralgia, we reduce as much as possible the time between one scan and the other scan of the excite of the system of the tracking system. So we reduce as much as possible, just to reduce as much as possible the intrafraction motion. The intrafraction motion, of course, it's a problem, but we have clinical results which demonstrate clearly that this intrafraction motion, which is more theoretical than true, than real, because we have clinical results, it's not one patient or two patients. We are outside the experimental stage of this procedure. We have hundreds and hundreds of cases treated worldwide, and most of them has not been reported yet. So, and no complication that can be attributed to intrafraction motion have been reported to date.
And I would argue that that's one of the most compelling parts of your presentation today, that image guidance can be as accurate as is. And in giving now a shout out to the ZapX, I mean, the ZapX uses the same basic principles of image guidance, and it should be as accurate, if not more accurate in most situations, as the CyberKnife. But it also combines a more optimized beam at 4 MV with a shorter SAD and a better collimation system. We think and believe that long term that the ZapX should deliver even superior superior clinical outcomes above and beyond the CyberKnife and maybe even the Gamma knife for conditions like trigeminal neuralgia because of those attributes. Now, maybe time for this one or two last questions. And so this is a criticism of the technique here. He said, I'm afraid that many patients exchange pain for numbness. So think of from the patient's perspective, how would you say that radiosurgery is in fact the right solution for most patients, and given this criticism that patients are exchanging pain for numbness? Do you agree with that, or is that just very this is one?
No, I have to say that this is quite weird for me because patients have the clear. Sometimes you can have a mixture if you are very unlucky. You have a mixture of pain which changed is a way of manifesting itself, and you have a mixture of hypoesthesia. But these are the great minority of cases. In most cases, the patient had no pain. In most cases, some of them will develop some sort of hypoesthesia that after one single treatment using that fixed parameters, because this is very important. If you go outside those parameters, I believe that you will have different results because the system is very can give you several options, and so it is important that you respect those parameters. But if you stay in those parameters, the risk of having severe hypoesthesia for me is close to 0%. And it's quite clear on the patient that have still pain and the patient who have a slight hypoesthesia or an hypoesthesia which is limited to a certain area of the face. It's something that I don't feel it is really relevant.
I mean, I've managed a lot of patients with trigeminal neuralgia myself, and I've almost never seen a patient who wasn't glad. Even those who end up with facial numbness aren't happy to exchange the pain for the numbness.
Yeah.
And so if you take care of many patients with trigeminal neuralgia, you understand just how debilitating it is. And yes, the perfect result, and you get this perhaps most often with microvascular decompression, is to have normal facial sensation and no pain. But if the worst happens and you do get facial numbness, patients seem to be all very grateful nonetheless.
Yeah, completely. I completely agree with that. So 70% is not far from the results of microvascular decompression, I believe. We are not far from that results.
What do you use for your MRI protocol?
We use the classical CISS or Fiesta volumetric sequence, and then we use T1 for contouring all the structures surrounding, and the CT scan, of course. We don't use cysternography. I don't feel it is really important, and I rely on CT, T1, and Fiesta sequence. I believe that this is enough. It's another question that has been debated in the past, but now it is quite evident that you don't need cysternography.
And you're targeting the nerve just distal to the Meckel's cave, correct?
Yes, it's close to the Meckel's cave. Yes, immediately after the Meckel's cave, at the entrance of the Meckel's cave. Also because the geometry of the pins, it is very rare to have the dose to the gaster ganglion. Most of the dose falls on the temporal lobe, which is something that we need to take care of, but it's not a big problem, and on the brainstem posteriorly. Never seen an excess of dose on the gaster ganglion, so we can be quite close to the gaster ganglion.
This is the last question. I think it may be from a fellow Italian. Question is, if a patient's treated in a traditional way, and I'm going to say maybe that's MVD or whatever the traditional way is, how long do you wait before you treat with the CyberKnife or with radiosurgery? Any rule of thumb?
Oh, but if the MPD fails, you can treat immediately. So let's say there's no reason to wait after failure of MPD. If you choose that MPD is the first line treatment for you and for patient, which is okay, I can agree on that. But after the failure of MPD is a failure and stop. You cannot wait for 2 years, 3 years that the pain disappears. So you can treat also immediately. The opposite can be a problem. So let's say doing MPD or rhizotomy after radiosurgery has been reported to be a problem because the nerve can be thinner. This has been said. Never seen a situation like that, but it has been said by some surgeons that the nerve can be compromised by radiosurgery. I'm not really sure that this happened. Anyway.
I have a friend of mine, a neurosurgeon here in the Bay Area, has done a handful of such cases post-radiosurgery, and he reports that there's no difference, no problem at all doing these post-radiosurgery in a failed case. Well, there are a few more questions, but I think we're going to call it a day. We may answer some of these questions offline, but I'd like to thank Alfredo for brilliant discussion and presentation and in our kickoff inaugural webinar series. And thank everyone for participating in today's call. And I welcome you to future webinars every week for the next 10 weeks. Okay. Thank you all and have a great day.
Thank you.